Welcome, everybody. My name is Karen Lundgren. I'm a Medical Affairs Manager with Nestle Health Science. It is my privilege to introduce today's speaker and assist with this educational session on the Adult Malnutrition Consensus Criteria, how to apply to your practice. Ainsley Malone is currently a clinical practice specialist with the American Society for Parenteral and Enteral Nutrition, ASPEN, an organization dedicated to safe, efficacious, and high-quality nutrition care. She is also a dietitian member of the nutrition support team at Mount Carmel West Hospital in Columbus, Ohio, where she is involved in the management of patients requiring enteral and parenteral nutrition. Ainsley is a co-author of the May 2012 published consensus statement addressing characteristics recommended for the identification and documentation of adult malnutrition. Ainsley is a leader in malnutrition-related activities, having served as a representative to the Academy of Nutrition and Dietetics Malnutrition Work Group and serving as a member of the Global Leadership Initiative in Malnutrition Working Group. She recently served on the 2017 to 2018 Ohio Malnutrition Prevention Commission. With that, welcome Ainsley Malone.
Thank you so much, Karen, for that wonderful introduction, and thank you and Nestle as well for inviting me to be a part of today's event. I'm really looking forward to sharing my expertise and my experience in this malnutrition consensus diagnostic approach. And I also want to thank all of you as attendees for taking time out of your day to listen to hopefully great information that I will share with you. These are the objectives that I would like to achieve today. The first one being that following today's presentation, you'll be able to describe the practical steps for determining an adult patient's malnutrition etiology. You will also be able to describe the 6 malnutrition criteria and outline processes for identifying those criteria in specific patients. So we'll go through all the criteria, some practical points related to determining those in patients, and then I have 3 case studies that I'd like to share with you. The last objective, I was a little bit overzealous in what I thought I could accomplish in 45 to 50 minutes, and so we're not going to really outline a full implementation process, but what I would like to do is share with you some information on the usability and feasibility and how this approach to malnutrition diagnosis is occurring within the United States. I think I don't need to really tell you, because I believe I'm preaching to the choir, that malnutrition is certainly a long-standing issue. And interestingly, as early as the 1930s, there was a first report of a relationship between a nutrition issue and a negative outcome. And this was in JAMA. Hiram Studley was a surgeon, and he began to recognize that his patients who needed surgery for peptic ulcer disease who lost weight, more of those individuals died compared to those that didn't lose weight. And so to me, this is really fascinating that something such as this happened so long ago, but clearly was the beginning of what we now know is malnutrition and the negative outcomes associated with it. I'm sure some of you remember the skeleton in the hospital closet. There also have been just a myriad of articles focused on the importance of addressing malnutrition in the hospital setting. And so I think we all recognize that this is not a new issue. And interestingly, this slide highlights the prevalence of malnutrition over about 40 years' time. When you look at the very first prevalence data up here in this table, this was Bruce Bistrian and George Blackburn's original study in 1976, and their incidence of malnourished patients was 44%. And the range is, pretty significant, but generally about the same in terms of overall prevalence. Now, certainly it will be different depending on the patient population, as well as the methodology used. What I have highlighted for you in this particular red box on the slide is the prevalence data for these 6 individual studies are all data from those individuals who were diagnosed as being malnourished using the Academy consensus characteristics. So The prevalence is still pretty significant using this approach. I want to share just a brief bit of information on the impact of malnutrition on patient outcomes. This was a study done by Fry and colleagues in 2010, looking at the national inpatient sample, which is part of AHRQ, or the Agency for Healthcare Research and Quality. And this basically represents hospital discharges across the United States. And what these researchers did is they looked at individuals within this database and compared those who had a diagnosis of malnutrition versus those that did not. And you can see that those who were malnourished had a significantly higher incidence of these complications that you see listed on the slide. My next slide goes into it in a bit more detail. These are all the different complications, and these researchers focused on those complications that, as we know, currently do not garner any type of reimbursement if they develop while the patient is in the hospital. So these are important for all of us to have certainly an understanding about. But when you looked at the pre-existing conditions and all of these types of complications, weight loss, malnutrition, and weight loss, this raised the risk of developing these particular complications or conditions to a much greater degree. So if an individual was malnourished, they were 2.5 times more likely to develop a C. difficile infection compared to those that did not have malnutrition. And so these authors concluded that weight loss and or malnutrition significantly increase risk of all of these complications. So I think this really shows us that being malnourished certainly increases our risk of developing problems. This was a study done in the Veterans Administration population, and this was one of the first that looked at individuals diagnosed to be malnourished using the Academy Aspen consensus characteristics. And these were the different outcomes that they evaluated in those patients that they studied. And as you can see, these are the odds ratios here. So those individuals who were malnourished were over three times more likely to be readmitted within 30 days. They were more than 5 times likely to die within 90 days of discharge. So again, just pointing out that negative outcomes certainly are more prevalent in those who are malnourished. This last data point that I'd like to share, or data analysis, this was again looking at that AHRQ national inpatient sample. This was done with Aspen and AHRQ, and we looked at malnutrition patients discharged from hospitals with a diagnosis of malnutrition, and they compared those patients to those who did not have a malnutrition diagnosis. And what they found was that the death rate was 1.5 to 5 times higher than those who were not malnourished. Their hospital stays were longer, and they were much more likely to have a non-routine discharge, which would mean they weren't going home. They were going to an extended care facility. They were going to an LTAC compared to those who were not malnourished. And then these are just 2 additional outcome studies that have been done recently comparing patients who are malnourished versus those that aren't, using the Academy Aspen consensus approach. And you can see these are both retrospective reviews. Length of stay was certainly longer in those who were malnourished. 30-day readmission rate was longer, or was greater rather, and mortality was greater in this particular study. In this study by Mosquera, the only significance was the length of stay was longer. But again, I think you can see a pretty significant signal showing that negative outcomes are definitely more common in those who are malnourished. Now, Karen mentioned at the beginning, this was the publication that brought forth the consensus characteristics that were developed by a work group of both the Academy of Nutrition and Dietetics and Aspen. And I was fortunate to be a part of this. This was published in May of 2012. And in that, prior to this publication, the diagnostic approach that most clinicians were using, and I can remember doing this because I've been in practice for a little bit of time, we used all kinds of different criteria. We were using BMI, we're using percentage of ideal body weight, we were using perhaps weight loss, but nothing that was really standardized. And I think this is true for a lot of a lot of facilities, a lot of dietitians across the US. And so this really brought a standardized approach to assessing and diagnosing malnutrition. And one of the first aspects of this approach was introducing the concept of inflammation, recognizing that disease and malnutrition can often go hand in hand. So it's disease-related malnutrition in some instances, and so having an opportunity to assess for the presence of inflammation really brings that disease entity into focus. And so this was really the first part of the publication. And essentially, nutrition risk would be identified through a screening process, and then the assessment of inflammation would be the next step. And then determining the etiology of an individual's malnutrition would be based upon whether inflammation was present, and if so, was it a mild to moderate degree, which then would be chronic disease related malnutrition, or if a really heightened, a very severe inflammatory response was present, then it would be acute disease or injury related malnutrition. And if there was no evidence of inflammation, that would be malnutrition related to purely starvation or more of your social, environmental type of reasons for what is occurring with that particular individual. And I think for most of us, our classic example would be the individual with anorexia nervosa. So that really kind of was what the work group first discussed when we were developing this consensus approach. And then we went into, following this etiology focus, we went into determining what the specific criteria would be or characteristics. And we did use an evidence-based approach as well as a consensus-based approach, certainly recognizing that some of what we included here is a consensus opportunity. But these are the 6 characteristics that the work group identified would need to be assessed to diagnose malnutrition. And then if any 2 or more of these were present, then that individual would be diagnosed to be malnourished. And the severity of the malnutrition would be based upon various thresholds. And we will get into the thresholds when we discuss the individual patient characteristics or the individual patient cases. I didn't mean to skip over this. I'm going to go back a little bit. But you can see the characteristics are related to weight loss, evidence of inadequate nutrient intake, physical assessment in the form of assessing for loss of muscle mass and loss of subcutaneous fat, and then fluid accumulation and a functional measure, which is reduced hand grip strength. So now we'll kind of go into the etiology discussion and assessing for inflammation. And I just wanted to share with you, I think, just some basic background information on the inflammatory response. And even though this slide says it's acute, some of this is also occurring in the individual that has a low level, mild to moderate degree of inflammation. Some of this is occurring as well. And you'll see this manifested in some of the future information that I'll be sharing. But certainly you can see there's a release of cytokines, a release of some acute phase proteins, a decrease in the visceral proteins that are typically synthesized. As you see here, CRP levels or C-reactive protein is one of those acute phase proteins, and it will increase. The increased catabolism leads to an elevated resting energy expenditure and a negative nitrogen balance. And certainly, as clinicians, you are all aware of this, but I wanted to just kind of review to bring it into context. From a laboratory perspective, these are indicators of some degree of inflammation, and you can certainly recognize someone who is acutely and severely inflamed. You're going to see significant elevations or alterations in these particular parameters. And I'm sure those of you that are working in an ICU environment have certainly seen these, but these would all be indicative of an inflammatory process. When I specifically mentioned C-reactive protein, that is one of those acute phase proteins that were shown in that previous diagram. And it is a major acute phase protein, and it is a pretty effective measure of general inflammation. In an individual who is highly inflamed, you'll see a significant rise in C-reactive protein. And it can last certainly for a long duration if the individual is very, very inflammatory and that inflammation occurs for a significant period of time. These are some other acute phase proteins that are released by the liver in this inflammatory phase. Individuals that have chronic disease, such as those with organ failure, like COPD or CHF, there are elevations in some of the cytokines that I mentioned before. And so these, as well as acute phase proteins such as CRP, so these are also indicative of the chronic setting having an inflammatory component. From a clinical perspective, these are all aspects of a patient's clinical status that would reflect an inflammatory process. So an individual who is febrile, or on the other side, who has hypothermia, someone who is infected either through a urinary tract infection, or pneumonia, a bloodstream infection, an abscess, all of those would lead to an elevation in some of those acute phase proteins reflecting that inflammatory process. I've taken this information from the most recent Aspen Adult Core Curriculum. Andrea Jeven was the primary author in this particular chapter. And in that chapter, it delineates some of those diseases and conditions that are associated with the mild to moderate inflammatory response. And some of these were included on that etiology diagram that I described earlier. But you can certainly see a lot of these are chronic diseases that do have an inflammatory component to them. And I think this is very helpful when we are diagnosing malnutrition and assigning an etiology to that individual patient's malnourished state. And this again would then be those conditions that are associated with a severe inflammatory response. And these are all fairly obvious. These would be mostly your patients in your critical care units. So ARDS, closed head injury, trauma, severe acute pancreatitis, etc. So now let's get into the specific malnutrition criteria. Let's start with the insufficient energy intake. This is something that has been nicely delineated by Jans Kondrup, who is a leader in the European Society of Clinical Nutrition and Metabolism. And this is a really great article that highlights the real important aspect of achieving adequate food intake or energy intake. And we gleaned some of our threshold information based upon data from this particular paper. But obviously, we need to review our food and nutrition intakes, and we compare what someone has actually consumed versus what their requirements are. And then the inadequacies of intake are reported as a percent consumed over a specific time period. Now, the devil is somewhat in these details here, and someone who's been using this diagnostic approach in our facility since 2012, certainly some of this is easier than others. And I will say, with the advent of the electronic health record, some of this information is more easily obtained. Typically, we do need to assess actual intake from interviewing our patients and or their family to get a fairly accurate diet history, 24-hour recall. As we all know, this is sometimes easier said than done, but generally speaking, I feel like we can get a pretty good sense of how well someone has or hasn't been eating. And so these are some of the questions that I typically will ask when going through. Sometimes you try to get a direct recall, but it's difficult in terms of, patient memory or family memory. And then I'll resort to, this more general question, have you been eating less than half of your normal meals, about half of your normal meals, or about 3/4 of your normal meals or less, just to kind of give a ballpark of how well or how well someone isn't eating. And then obviously, if it's someone that you're assessing beyond their admission, you're going to be able to have some documentation by what the patient care services or nursing team is documenting of someone's actual oral intake. Although I can certainly say, and I'm sure many of you have experienced this certainly has challenges, and some days of documentation are better than others. You can also certainly evaluate if someone's been on enteral feeding or parenteral nutrition. You can identify, what they've been receiving in their therapies and how, what percentage of their caloric requirements they've achieved. And certainly we're familiar with the approaches to estimating an individual's requirements. Unintentional weight loss, this has been a criteria that has been something we've all been addressing, or using rather, really for most of our time as being dietitians. At least for me, that has been the case. But we certainly have a better handle on thresholds and what kind of weight loss and what kind of time period we are using in our evaluation. It is a well-validated indicator of malnutrition, has been used for years. I think for those of us that have been using this, and many of you would agree, that there are lots of opportunities that can impact the accuracy of an individual's weight. So the underlying disease state, an individual's fluid status, and we'll talk about this when we talk about edema, equipment malfunction, human error, the bed scale wasn't zeroed out, or there are pillows on the bed or something on the bed that wasn't meant to be included in the weight. And then I think challenges for us are also in regards to recall errors. And I will say that having the electronic health record, as I mentioned before, is something that has been helpful, especially in patients that have been admitted, are, I wouldn't say frequent flyers, but if someone's been admitted within the last month or the last 6 months, you can certainly get good information of where their weight was at that time, and that can be helpful. And I have to say I have found that to be quite useful in some of the patients that we've evaluated. Obviously, usual weight is what we will use to evaluate weight loss and determine a percentage of weight loss. Obviously, I mentioned bed scales being more accurate. The accuracy of bed scale is dependent upon the accuracy of the user. Sometimes it just depends. I find standing measurements are better than reported measurements. Sometimes I have to go back and ask for another weight if I don't think that the weight that I've seen documented is actually accurate. And then I think one of the biggest things is estimating dry weight, and certainly I'm sure many of you do that. Obviously, I see a lot of patients that have come in for same-day surgery and then have their surgery and then have a complication, and we end up needing to intervene with parenteral nutrition or enteral nutrition. And so oftentimes the weight that is provided with the patient is after they've had their surgery, which obviously would not be their true dry weight. So sometimes I have to go back in the electronic health record and find what that weight happened to be, if they had a pre-admission physical or HMP that was included in the EHR. I will go back to that, or sometimes I need to ask the family. The next set of criteria focus on the aspects that we can achieve through physical assessment. And it's really an effort to help identify body composition. And so assessing for loss of muscle and loss of fat are going to be those aspects of body composition that we want to include in this diagnostic approach. There are potentially other options for assessing body composition, but really the most convenient is the physical exam. Although we can certainly do anthropometric measurements, tricep skin fold, calf circumference, calf muscle circumference, and you certainly will probably hear more and more about some of those in the future. But I think the easiest thing for us as clinicians that we can do is to perform the nutrition-focused physical exam. And this is something that I'm sure you're familiar with this, and many of you may actually be performing this. And this is something that if you're familiar with it, and you are, it's basically an exam which uses physical assessment and physical function findings to help determine nutrition status and diagnose malnutrition. It does involve both observation and palpation techniques. And in doing your physical exam, you are also talking with the patient, so you can confer findings with the patient. You can ask the patient, is this something you've demonstrated or displayed all your life, or is it something that you've noticed over time? One thing that I find very exciting about nutrition-focused physical exam is it's something that is so unique to dietitians and what we can contribute, because I'm sure, and I've seen this for many years, probably the only thing I see in regards to physical exam that's nutrition related, documented by providers, is in the very severely malnourished individual. I will see probably something like patient appears cachectic or a concave abdomen, but that's about it. And so I feel like this really is something that we can contribute to the history and exam and the diagnosis of the patient that no one else can contribute. It really is, I think, a rewarding approach in terms of the work that we do. The other thing that I have found in doing this for the past probably 3 or 4 years, 4 or 5 years actually, is that when we do this when we're interviewing the patient and having a conversation with the patient and their family. And so it really doesn't take that much longer to perform the exam. And I found that in doing this, you really develop an even closer relationship with the patient, and they become a little bit more invested in what you're doing and why you're asking the questions. And when they realize that you're assessing them, perhaps because they may be malnourished, they take a really more interested approach, and I feel like they're more willing to be involved in the decision making and being involved with what's going on with them nutritionally. So I have found that to be very, very beneficial. This has been made a standard of practice in the RDN competency standards of practice and professional performance. And Ascend has actually added this in 2017 as a competency for the DPD programs. I'm sure many of you have heard there are lots of training opportunities, including the Academy Nutrition Focused Physical Exam Workshop. There are many throughout the year. And then I just wanted to put, I know I'm, shouldn't be putting a plug, but I am involved with Dietitians and Nutrition Support, and we produced a nutrition focused physical exam video, actually partly due to a unrestricted educational grant from Nestle. We were able to complete this wonderful video that actually stars one of our DNS leaders performing exams on real patients, and has a moderator as well. So it's a really great video. I didn't mean to belabor that, but if you want more information, I can give that to you when we go through the Q&A period. So these are just obvious signs of severe loss of muscle, severe loss of fat that you glean when you're doing your physical assessment. These next few slides are really describing the areas to assess for both fat loss and muscle loss. This is something that is available on the Academy's website. You don't need to be a subscriber of the Nutrition Care Manual. This is on the Academy's website under if you search malnutrition or nutrition focused physical exam, you'll see this as a linked handout, and you can download this. But I like this because it gives you tips for performing the exam in that area. It describes what you would expect to see in someone that's demonstrating severe loss of muscle versus mild to moderate versus well nourished. So it gives 3 different descriptions, which I feel is very, very helpful when you are, beginning your work in terms of physical assessment and honing your skills. The next criteria is assessing for fluid accumulation. And this fluid accumulation is really fluid that would be considered nutritional related. And so if there's any other reason why an individual would be demonstrating edema, do they have congestive heart failure? Do they have renal insufficiency? Do they have some other reason? Do they have liver failure and have significant ascites? These are certainly things that would not be nutritional related. But if there are no other reasons why they have significant fluid edema, this would be considered to be nutritional. And the reason it was included in the consensus diagnostic approach is that it does mask weight loss. So in individuals who have significant edema that is nutritional related or not related to other issues, you're not going to really see any loss of weight, and it's going to be difficult in most instances to identify loss of muscle mass. Now, this is one approach to assessing edema, and this is what our facility or our healthcare system uses, which includes both a distance amount of edema, meaning the length of edema, as well as the pitting is how long it remains intact. So it gives you a visual amount of indentation, as well as how long that indentation lasts. And this is what is used in our healthcare facilities. So you can see, the significant differences between the 4 different stages of edema. And then the last parameter in the consensus approach for malnutrition assessment is a functional parameter. And we chose the hand grip strength because it really is, at this point, the only validated proxy for lean body mass. And until we have a valid functional tool, and I will say that the Academy is actually in the process of beginning its validation study, a very robust study. In fact, you may have seen about the recruitment efforts, and they will be assessing hand grip strength as a parameter, as well as other functional parameters, including some of these others that you see listed, ability to perform ADLs. There may be a performance scale that's included in that validation study. But at this point in time, a reduced hand grip strength measurement compared to normal values for that device would then be one criteria that would be met. It has been associated with being a independent predictor of poor nutrition status. These are 2 various devices that are available on the market. It's interesting about, I would say, in some of the studies that I have read utilizing the Academy Aspen consensus approach, about 30% of those individuals that have been surveyed in those various studies are using hand grip strength. And I think it's just some folks just haven't been trained or don't feel like it's not been brought into their facility. I will say that there has been a toolkit that's been developed, and it is available if any of you are members of the following DPGs, and I'm probably going to miss one, but healthy aging, clinical nutrition managers, dietitians and nutrition support, the oncology practice group, and I know that's only 4, so I know I'm missing one, but the toolkit has been made available to members of any one of those practice groups complimentary. So all you need to do is go to those websites and find, I know in the DNS website, it's in the DNS store, and it's complimentary. It has some journal articles, it has competency assessment, it has a how to perform the exam, and it's really, really very, very useful educational opportunity for learning how to perform hand grip strength. So let's move into our patient cases. This first patient, and these are all patients that have been in our facility, in the facility within which I work. This was a 59-year-old gentleman who came into the emergency department with acute rectal bleeding. He underwent a colonoscopy on his 3rd hospital day, which revealed a partially obstructing mass in his mid-rectal area, suspicious for malignancy. On his 6th hospital day, he underwent a lower anterior resection of his colon. And I'm not sure if any of you have had this experience, but his admission nutrition screen was 0. We do the malnutrition screening tool as our screening process, and his score was 0. So the dietitian did not assess him until he became NPO on his 7th hospital day because of his NPO status. And at that point, the dietitian on this particular floor did her nutrition assessment, and you can see the anthropometrics. He's 5'6" tall. You can see his current weight, his admission weight, and then his weight 1 month ago. So he had lost a fair amount of weight in that period of time. He was NPO since admission, so this was day 7 of his hospital course. He had been experiencing a reduced oral intake and anorexia over the last month, and he reported that he was eating about half of his normal meal during that month-long period of time. The dietitian noted in her physical assessment that there was no evidence of any subcutaneous fat or muscle loss. He was demonstrating 2+ pitting edema in his bilateral lower extremities. From a clinical perspective, he was demonstrating some pretty significant leukocytosis. He had a mild temperature elevation. His albumin was low. His prealbumin was low. And we don't use hand grip strength at this point in our healthcare system, although we are moving in that direction. But at this point in time, and when this patient was here, we didn't. But we noted that the dietitian noted that he was complaining of generalized weakness when he was admitted. according to the physical therapist. So the dietitian that did this nutrition assessment, her diagnosis was that, well, I could ask you. I'll say his weight loss was over 1 month. It was 6%. He'd had a 7-day NPO status, so no intake, and then he had reduced intake over the past month of about 50%. He was demonstrating moderate edema, and then his functional assessment was not part of the current criteria. So our diagnosis for him was severe malnutrition related to acute illness, as evidenced by his weight loss, inadequate intake, and fluid accumulation. And you can see this is the chart that we have laminated cards that we carry in our pockets, although most of this I've memorized, but sometimes the weight loss I have to look back on the card. But this is just an example of what our card looks like, and you can see I circled the criteria that this gentleman demonstrated. And so this shows that his malnutrition was related to his acute illness and injury. So our second patient is a 60-year-old male diagnosed with laryngeal cancer. He underwent a radical laryngectomy and esophageal reconstruction and grafting. When he was in the hospital for his procedure, he actually received enteral feedings, but they discharged him without his feedings on an oral diet. And subsequent to his procedure, and once he healed, he proceeded with adjuvant chemo and radiation therapy, which was a 6-week course. He developed remarkable problems with dysphagia and poor eating in that 6-week course, as you see on the bottom of the slide. He was having some difficulty before his surgery, before his diagnosis, but it had improved. But really, his problems profoundly started when he underwent his chemo and radiation. You can see his height, his current weight when we saw him was 140, and then his usual body weight before all of this began was 165 pounds. He had experienced a 25-pound weight loss over the past 3 months, which reflected a 15% weight loss. Physically, he was showing signs of severe loss of muscle. His temporal area was very hollowed. He had a significantly hollow depression. His clavicle was very visible. His patella was very visible. Did not show any evidence of fluid accumulation, and his albumin was low on the lower side. So as I said, his weight loss percentage was 15% over 3 months. He was eating really, I'd say less than half or about half or less of his normal food items over the past month. Severe loss of muscle and fat, and also complained of weakness. His diagnosis was severe malnutrition related to chronic disease, and that was related to his weight loss, his inadequate intake, and his muscle loss. And you can see on this particular chart, again, the same chart I used before, but just reflecting that chronic etiology to his malnutrition. Now, our last patient is a 78-year-old female who was admitted with abdominal pain. She'd had complained of a 1-month history of pain with nausea and vomiting. She had a long history of gastric dysfunction with previous gastric surgeries. She underwent a partial gastrectomy with revision of her Roux-en-Y gastrojejunostomy. She'd had one done before, and they placed a J-tube during this particular surgery. Because of her severe malnutrition, she was provided with TPN for 2 weeks before her Roux-en-Y revision. Her height upon admission was 98 pounds. Her weight was 98 pounds. Her height was 64 inches. And she was on TPN preoperatively and then postoperatively. And we transitioned her to full EN 10 days post-op. And it took a while. She was having some ongoing issues with tolerance, having some excessive stooling, combined with nausea. And it actually took 3 to 4 weeks to achieve goal maintenance energy requirements, which is a lot longer than I think most of us usually see or hope to see. I think part of the problem was she had ongoing issues with abdominal abscesses. We did another nutrition assessment 2 months after admission. Her weight had dropped down to 90, represented an 8% loss. You can see from a physical exam perspective, she was showing signs of moderate to severe fat and muscle loss. She was normal white count, afebrile, but her visceral proteins were on the lower, still below normal. So her diagnosis from a nutrition perspective, 8% weight loss over 2 months, her energy intake had been pretty reasonable. We were able to achieve over the past month 80 to 90% of her protein and energy requirements. And I remember actually going and calculating 30 days worth of intake just to make sure I had the right, information. She was showing severe loss of muscle and fat. So her diagnosis was, again, similar to the gentleman before, severe malnutrition related to chronic disease, as evidenced by her weight loss and fat and muscle loss. And I included this patient in our discussion today because this is not a patient that was diagnosed on admission. She was diagnosed to be severely malnourished, but her malnutrition 2 months later was the same. And so I think, these are patients that are in the hospital for a period of time, and we do need to be doing repeat assessments to see what is happening with them nutritionally during the course of their admission. So it looks like I have a few more minutes, so I just thought I would share with you a little bit of additional information about the consensus diagnostic approach. This was one of the first studies that was done following publication, really to describe the use of this approach in diagnosing malnutrition. And so these were some of the goals of this particular research group that conducted this study. They looked at 101 consecutive patients, and this was from 2 hospitals in Pennsylvania. I would say a third were non-ICU, a third were critically ill patients. This highlights the prevalence of malnutrition using this approach, as well as the etiology. So most of them were more of the chronic disease-related malnutrition, as 2 of the 3 cases I presented to you. Some of them were acute injury-related malnutrition, and then a few, but the least etiology approach was with the social environmental, and this is the pure starvation approach or diagnostic approach. And I included this slide just to give you a sense of the the percentages of characteristics that were observed in both the non-ICU and ICU patient population. So edema was used a little bit more, or was found to be a little bit more in the ICU patients. No edema was found to be, was not utilized in more of the non-ICU patients. Loss of muscle and loss of fat were characteristics or criteria identified more in the non-ICU patients versus the ICU patients. But energy intake and weight loss were fairly comparable between both the ICU and the non-ICU patient populations. And then just lastly, I'd like to just highlight that I mentioned some of the survey work that's been done since the publication of this consensus approach. And you can see that beginning in 2012, there were some, about a third of those surveyed, and this was all Aspen and Academy members, if I'm correct. Yes, Aspen and Academy members. So about a third were in the implementation process. And then up in 2016, and this was just Aspen members, 87% of the respondents reported using this approach. Dietitians and nutrition support, about 95%. Aspen and DNS are, mostly nutrition support practitioners, so you're certainly probably going to see this more likely in use. This was an Academy survey, the one I mentioned early on. There were 2 survey points in time, and the use of this approach increased from a little over half to a little under 3/4 from 2014 to 2017. So, and this reflects all, this was sent to clinical anyone in the Academy that has indicated that they are a clinical practitioner or a nutrition support practitioner. So a more generalizable population in terms of the survey respondents. So I think this probably is more reflective of what's occurring in the United States. And then lastly, I just wanted to add a couple of practice points. In doing this approach in terms of nutrition assessment, I would say it does take a little bit more time, not necessarily because of any one aspect. It's just you're doing a bit more of review of the clinical picture, looking for inflammation, assessing for the criteria, and trying to identify some of the data points. Also, I think we're spending more time talking with our patients and interviewing them and their family. And while you're doing that, we're also performing the physical assessment. So, and this is a range. I would say 30 to 60 minutes is variable. Obviously, I've worked with patients that I'm doing my nutrition assessment when after they've been in the hospital for a month, and I'm wading through a huge medical record. So, that's going to take a little bit longer. The other thing that I think is really exciting is that, not that we have, certainly we've had many opportunities to verbally communicate with our providers, but I feel like when I diagnose malnutrition in an individual, and there's some opportunity for me to verbalize that with the physician, so that especially if they're not on any kind of diet, or if they're eating very poorly, we can begin a conversation pretty quickly about what we're going to do in terms of whether we're going to, start enteral feeding, or if their GI tract isn't functioning, are we going to start parenteral nutrition? So I feel like this sets up a really nice opportunity to communicate with our physicians. And then, as I mentioned before, I think we really have an opportunity to invoke some good shared decision making with the patients that we're working with, and giving them the opportunity to better understand what's happening with them nutritionally. So with that, just to summarize, and I think I'm going to let you review all of these, because I want to get to what I think will be, a fair number of questions. All I can say is I am very excited to have been able to share some of my experience and expertise with you.
Thank you so much, Ainsley, for just a really informative session today. And we do have some questions from the audience. Our first question comes from Mary. How do you practically include hand grip strength in your practice? And how many tools do you have in your medical center?
So as I mentioned before, thank you, Mary, for that question. We are beginning to bring hand grip strength into our healthcare system. We're a 4-hospital healthcare system, and so we're beginning to take a look at how to do that. I will say, in working with, and I'm involved with a lot of other groups throughout the country in terms of leadership, and what I have learned from those that are using hand grip strength, just one device has, though, has been brought into a facility, and really, I think it can't be used on every patient. Not every patient is going to be able to perform a hand grip strength exam, or procedure rather. But those that have, those that are able to, it's a very useful process or procedure to utilize, and those that have been trained and have been educated do find it to be a very useful parameter to assess. I also feel that if you're doing anything in the ambulatory care setting, this would also be a great procedure to integrate into your practice.
Okay, thank you. Ainsley, do you perform nutrition-focused physical exam on patients that have obvious fat and muscle loss, or do you reserve time for this on other patients that are more questionable?
Well, I mean, obviously, the minute you walk into a patient's room, you are observing, correct? You're observing. And so if you see evidence of loss of muscle and loss of fat, I still like to go in and begin, doing some aspect of physical assessment, because you can get a sense of how severely hollowed that temporal depression is, and you can get a sense of, you can visually see that, but you can also ask the patient, especially in certain areas like the clavicular area, or perhaps the triceps area. I know someone in my neighborhood who has the thinnest arms I've ever seen, and I said to her once, I said, you would meet the malnutrition criteria just by looking at you, and she said, well, that's the way I've always been. I've always had skinny arms. And so I think it's important to continue to perform the exam, because then you can have that conversation with the patient, and you can then confer or confirm that this is something that has occurred over time, or if it's something that has always been that way. You know what I mean? Because there is individual variation from patient to patient.
Thank you. Do patients ever meet criteria that fall into separate malnutrition categories? And if so, are you able to diagnose malnutrition still if a patient only meets one criteria in 2 to 3 categories?
Well, that's a good question. I've seen where patients fall into both, like we could diagnose them in 2 different categories, and there's really no one or the other that, there really isn't a benefit. I guess I would tailor that into what their what the reason for their presentation was. Are they suffering from a chronic disease, and then came in with acute flare-up of something? I think that until we have in the ICD coding system, until we have specific diagnostic codes for the various etiologies, it's not, it wouldn't be as beneficial to choose one over the other. I tend to focus on what is, I guess, occurring with the individual on a more ongoing basis. I haven't really ever, I guess there could be someone who has meets one aspect of a criteria that's a severe threshold and one that's a non-severe threshold. I guess I probably in that instance would err on the side of caution and go with the non-severe, just because of and you may be familiar, or your managers may be familiar with some of the malnutrition denials that have been occurring within CMS as well as the private insurance industry. And some of it, it's unfortunately quite challenging, because the reviewers that have done audits have provided really outdated criteria. And so I think, just to be on the cautious side, I would err on the non-severe side, because if only one of the severe criteria is met, then you really can't say someone is severe. I think I would probably shoot for the non-severe.
Okay, you have referenced albumin. Knowing the relationship to stress, what is the rationale for continuing to address?
Well, I referenced it not as a marker of nutrition status, but just a marker of inflammation. And that's truly what it is. When you think about that diagram that I showed you before, and I'm sure this is something that you obviously are very much aware of, that when someone is inflamed, they're not going to be the synthesis of albumin and prealbumin and transferrin are all going to decrease. And so that is reflected in lower levels, but it's not one of the criteria for nutrition assessment. It's not one of the criteria to diagnose malnutrition. It can be used to help pinpoint inflammation and help guide you in terms of, determining whether someone has an inflammatory process going on. And that's really the only usefulness of it. And it would be just one of those other parameters that you might have available. If there is no prealbumin or albumin level, I wouldn't order it. But if it's something that someone else has ordered or is available in if someone has ordered a liver function panel, for example, you're going to see an albumin level, and that would just be something that you would add to the clinical picture that you're pulling together to support the inflammatory process.
Thank you. Where or how can we access the nutrition-focused physical exam video that you referenced in your
So
session?
if you go to Dietitians and Nutrition Support website, which is www.dsdpg.org, there is a store on one of the tabs in that on that website, and there's a member store and a non-member store, and that is where the video is housed for sale. There's a member rate, there's a non-member rate, and there's actually an institutional rate that can be purchased by an institution for an X amount and can be viewed by any number of individuals, and the CE could be available for any number of individuals with that institutional pricing.
Thank you. I think we are about out of time. So again, thank you, Ainsley, and a big thank you to our audience for your participation today. We really appreciate it. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice. Thank you all and have a wonderful day.